You can see the presentation, right now?
Yep, I can.
Okay.
So actually, yeah, we can go ahead and begin right now. So welcome everyone to our shadowing session. This is Dr. Avneet Sodhi-Gaur. I hope I'm saying that
Yes,
correctly.
you're saying it right.
And then she'll be talking about ophthalmology today. So you can take it away.
All right. Well, thanks for joining us. I really like this platform of how you guys set this up because it gives an opportunity to, shadow or virtually shadow different subspecialties in medicine that, may not have as much exposure in med school or even before med school. So this is really great. I really love what you guys have done, honestly. I
Thank you
wish I
so
had this when I was, before I joined med
much.
school. So my name is Avneet Sodhi-Gaur. I'm the director of the glaucoma service at a CLI Institute in Los Angeles, as well as cataract and LASIK surgeon here. So I'm going to talk about ophthalmology. Oh, why is this not? Okay. So a little bit about myself. I did my undergraduate training in Washington, D.C. at George Washington University. I was in an early selection medical program. You probably have heard about different medical programs that you are accepted early into med school and don't have to take MCAT. So I was in a program that I applied in my college, not in high school. So and I was early accepted in my sophomore year and went on to the med school there. So I continued on medical school at George Washington University and did my medical internship there at GW as well. I'm originally from the Maryland area, so I didn't want to move away from home. So that's why I was in that area. And then I thought, okay, this is good to venture out. I need to venture out of the DC area. So I went to Boston and I did my ophthalmology training there at Tufts Medical Center and stayed on for my glaucoma fellowship at Tufts Medical Center and Mass Eye. And then I moved out here after I got engaged and married to my husband. My husband's originally born and raised in Los Angeles. And so that's what led me out to Los Angeles. So I just wanted to go through what is an ophthalmologist. So ophthalmologists are physicians. We go to med school. We're either an MD or a DO. We diagnose and treat all eye diseases. We perform eye surgeries as well as orbital surgeries. We can prescribe fit glasses as well as contact lenses. And essentially, it's about a total of about 9 to 10 years of training. So you do 4 years of medical school, 4 years of residency. It's about a 1 to 2 years optional fellowships, and the fellowships are basically retina, cornea, which is the surface of the eye, glaucoma, which I did, oculoplastics, which are more eyelids and orbit, neuro-ophthalmology, pediatrics, and any disorders of eye movement, uveitis, which are including inflammation in the eye, and ocular oncology. Then we are required to take a written and oral boards, typically at the end of our residency and into fellowships as well. Okay, so one thing that gets quite messed up is the terminology in ophthalmology. So an ophthalmologist, that's what I am, we medically treat all eye diseases, as I said, and we performed eye injections, lasers, and we perform surgeries. It gets quite interchanged with optometrists, but optometrists, basically the difference is that optometrists are able to treat some eye diseases. It can vary from state to state on how much you can treat. But they can also specialize in special contact lenses for the eyes, low vision management, vision therapy, so on and so forth. But for the most part, optometrists are not able to do injections in the eyes or do any surgeries or lasers. And then opticians, they're the technicians who basically design the eyeglasses, make the eyeglasses, but they cannot perform any vision screenings. They can't write any prescriptions. They're not permitted to treat any eye diseases. I'm going to answer these while I go, so we don't have an upload of questions at the end. So what are some common disorders that you treat with surgery? What are common things that can go wrong during eye surgery? And do you think the option of surgery and going through medical school gives an ophthalmologist the opportunity to treat a wide variety of diseases and pertaining to the eyes? Okay, so I'm going to answer number one, the question, what are some common disorders that I specifically treat with surgery? So number one outpatient procedure in the United States is cataract surgery. So that's a pretty common condition that we do, majority of ophthalmologists do. I also do quite a bit of glaucoma surgeries. And then in terms of what can go wrong in eye surgery, the main things that I will tell majority of my patients are that the risk of eye surgery, there's always risk of infection, there's always risk of bleeding, always risk of second surgeries needed if there's any complications that go on. And depending on the surgery, I tell them what other additional complications could happen. Luckily, the complication rates for cataract surgery in specific is extremely low, and I let them know, obviously, if they're at higher risk for a certain complication, it's always very important to tell the patient so that they understand and, they sign a consent form. And with especially certain surgeries, I have 2 evaluations. So they come in for a cataract evaluation. I'll talk to them about the surgery process, about the different lens implants that we place in the eye. And then I also talk to them about like the process of the surgery. It's quite a bit of information that I give them the first day that I meet them. So I actually set up another appointment that's where they meet my surgical coordinator and they go through all the same thing that I tell them. So it just kind of reiterates everything. And they also ahead of time get information about cataract surgery, the risk benefits, so they can do their research before meeting it. So it's really important, with these surgeries to break it up. So it's not a huge information at one point of the time, because you can only retain a certain amount of information at one go. And then, do you think the option of surgery and going through medical school gives ophthalmologists the opportunity to treat a wide variety of diseases pertaining to the eye? Yeah, so I will give you some, I'm going to present some cases that, ophthalmologists, a lot of people, kind of the general public will think, okay, well, ophthalmologists, you just treat only eye diseases. You only treat give glasses, contact lenses, cataracts, do the LASIK, and that's it. You don't care about the rest of the body. The rest of the body doesn't affect the eyes. And I'm going to show you some case presentations of my own patients, and they've given permission for me to present these. That gives you an idea that what ophthalmology can entail and what kind of diseases that we do encounter from time to time. And then I'll answer one more and then I want to proceed. So how has COVID affected your practice, and what is an interesting case that you have dealt with? Okay, so COVID definitely, number one, when we had completely closed down, there was a lockdown, we couldn't do any elective procedures. We were only seeing emergency and urgent patients. And so that definitely, we slowed down quite a bit. When things started to open up, and in our office, we space out our patients. I'm not seeing as many patients as I was before. I definitely want to space them out. The one thing interesting that did increase was LASIK. The LASIK numbers increased quite a bit because number one, we're wearing masks. And when you're wearing glasses, people hated the mask with glasses because they would fog up, right? That's number one. Number two, people had more time to come in for LASIK, and they've been if individuals saved up money for LASIK, they're like, what better time to do it? So it's interesting. I performed more LASIK than I did before. And so my glaucoma patient population who are older, they hesitated to come in. So that was a little slower, but now pretty much everything is back to normal, to how much normal we can get. And then in terms of our, we have COVID policies. We send patients screenings beforehand. We make telephone calls just to screen them to make sure that they don't have any risk of COVID or have COVID. We test patients 3 days prior to their surgeries for COVID. So yeah, we're taking all the precautions as possible as kind of what other medical buildings are probably doing. Okay, so I'm gonna go a little bit further before I know a lot of questions are coming in, but I just kind of want to go forward in this presentation. So what is my specific day? I'm in a private practice. I work about 4.5 days total right now. I do 3.5 days in the clinic, and I have 1 surgery day. In my clinic day, I see about 30 to 35 patients a day. For our practice alone, we don't see any HMO patients. That's just kind of how our practice has been designed. It's been designed like that for about 30, 40 years. So we're all based off of referrals from primary care doctors to other medical doctors to optometrists. We do a lot of co-managements with optometrists in the Los Angeles area. In my day, I'll see a little bit of complete eye exams. I do a lot of routine and surgical glaucoma management and evaluations. I do a lot of evaluations for cataract surgeries. I do a lot of evaluations for cataract or for LASIK as well. And I see my postoperative glaucoma and cataract patients. And I do a lot of dry eye procedures as well. And in-office eyelid excisions and lesions. My surgery days, I have about 5 to 6 surgeries in a day, and they can be either a complex surgery or a non-complex, straightforward cataract. Most of mine, since I'm a glaucoma specialist, I do quite a bit of complex surgeries in my day, so I can't fit in 10 to 15 surgeries in a day. I have to do about 5 to 6 because they are longer surgeries. I do also do a surgery called implantable contact lenses for improvement of vision if they don't qualify for LASIK or PRK, and I do also LASIK and other refractive surgeries. And again, these clinics are very fast-paced with a lot of exposure to different various medical diseases, and I'll kind of present to you 2 different recent cases that I had. And it's very highly procedural and surgical based, as you can see. And then you get instant gratification. Okay, so meaning that most patients, you're able to help instantaneously their vision, especially with cataract surgery and LASIK. The patients are extremely happy the next day when they come for their post-op. And I'll give you evidence. I did my surgeries yesterday, and I have more gifts up front, but this is a gift from my cataract post-op today. So kind of shows that, patients are so grateful that you can improve their vision and improve their quality of life. So I'm going to present this case of this 30-year-old who actually came to me. He had moved, I think, from Ohio, he said, and he literally landed and within the next day came to me, and he had said that he had just acute onset of blurred vision in his left eye for about a week. And he said he was under a lot of stress with work and moving and other personal issues. Otherwise, he said he was very healthy. He had no other surgeries in the past. He was not on any medications. He had no other allergies. And his vision exam, so he was 20/30, and OD means right eye. He's 20/30 in the right eye, which is basically, if you think of the 20/20 line, it's 2 lines above the 20/20 line. And then he was 2200 in the left eye. OS is the left eye. That basically means, think of the big E. It's 1 line better than the big E. So he was blurry in that eye. His eye pressure was 16 in the right eye and 17 in the left eye. That's within the normal range of eye pressure of 10 to 21. Anterior segment means that the front of the eye exam was completely normal, but the back of the eye, so these are called fundus photos. Okay, the fundus photos of his right eye, which is on the left-hand screen, and the right eye that's on the, the right eye on the left-hand screen and the left eye on the right-hand screen. And basically this is showing that there are multiple areas of white lesions on his retina, if you can see, and these are on both eyes here. So I'm pointing it out here. You can kind of see these. And when I also looked in the eyes, there was kind of these whitish floating things inside the eye, like there's inflammation in his eye. So, you know, obviously there's something going on in both eyes. And so I did imaging of his eyes. That these are imaging called optical coherence tomography. And this is taking images of something called his macula, which you use for your center of the vision. This is the right eye on, and this is the left eye. And when I'm pointing, I don't know if you can see my pointer, but this is the inside of the eye, the outside of the eye. And you see these little whitish lesions here. Can you see my pointer? I don't know if you can see my, okay. These are little whitish, what we call vitritis or inflammation in the vitreous, which is a gel inside the eye, and then same thing on the left one. So there's inflammation going on in his eyes, as well as this is kind of normal, what you should see, the image. But in his left eye, there's a little pocket of fluid. And so, you know, he has inflammation with a pocket of fluid and some white lesions in both eyes. So there's a differential for this. And the differential, I like to break it down on, in ophthalmology, there's syndromes that cause these whitish dots inside the eye, inside the retina. So I'm not going to go through all of these, but this is the differential. And a differential diagnosis helps you to attack kind of what the patient is presenting with. And I'm very systematic in meaning that I like to break down things in terms of their sections, like what are infectious causes, what are cancerous causes, you know? So it just kind of breaks it up so that you're not jumbling and kind of, okay, I'm going to randomly going to say different differentials, right? So these are the differential diagnosis for particularly how he presented. And so because of his age, and because he also was sexually active and so on and so forth, I sent laboratory for syphilis, for TB, and toxoplasmosis. Those were kind of my biggest things kind of working first that I wanted to make sure he did not have. So his TB testing came back negative. His toxo came back negative as well. He was positive for syphilis and he was negative for HIV. By default, you always want to get HIV testing in if you're testing for any STDs. So this is actually a case of syphilis. And so you can see ophthalmologists we're the first ones sometimes diagnosing infectious causes. We're not just, you know, looking at cataracts and just doing cataract surgery. You know, we're very extensive beyond the eye because there are some things that present first initially in the eye. So this specifically, what this diagnosis is called is acute syphilitic posterior, meaning that it's inside in the back. Placoid, just describing that these are kind of more circular flat lesions. And chorioretinitis, anything that says itis is inflammation. And this is telling me where in the retina, in the choroid. The choroid is the deepest layer in the retina. So the name basically tells me how fast acute syphilitic, what is it that is causing the infection and where exactly in the eye. So this was the diagnosis for this patient. He is doing actually very well. He basically got treatment, which I will go over what the treatment is. You know, syphilis is broken down into 4 stages. There's primary syphilis, which you have this kind of painless lesion that happens about 2 to 6 weeks after the infection. Then you have secondary syphilis, which causes kind of non-specific symptoms. And then there's latent syphilis, which is kind of undetectable. It can persist for years. And then when it's tertiary syphilis, it's considered neurologic. So it also includes if it presents in the eye. And then you can also have cardiovascular heart manifestations too. And this can happen months to years following the infection. And so kind of further investigation with him after this came back positive is when he said, oh, well, yes, I had something in the past. And then that's kind of where it disclosed, but it didn't really dawn on him to kind of, give that sort of information before. And so there are a lot of syphilis in the eye can cause pretty much anything. It can involve any eye problem, any structure in the eye. It can cause a conjunctivitis, which I'm sure you guys have heard. It's just the white part of the eye that gets inflamed. Other conditions in the eye. So anywhere you have a structure, it causes inflammation essentially. And then there's ways to test syphilis. Why I got the something called the RPR. It's a rapid plasminogen. It basically tests for antibodies directed against the host antigen, right? And so the advantage to getting this RPR is that you can detect how active the disease is. And also when you treat them, you can see the response to treatment as well. So that's the advantage of getting that, but it is limited in its sensitivity. You can have a lot of false positives with that in like collagen vascular diseases or anything like that. So you could still be positive for RPR, but not have syphilis. So you want to get something called the FTA, which measures the amount of antibodies directed right towards syphilis. And so that's very highly sensitive. And again, as I said, there can be false positives in collagen vascular diseases, advanced age, or HIV as well. So the treatment, when it affects the eye, it basically is neurosyphilis. So the eye is just an outpouch of the brain. And so you want to treat this appropriately. You have to give IV penicillin daily for about 10 to 14 days, and then you give intramuscular injections of penicillin for about 3 weeks. So really, really important. You can't just give intramuscular injections of penicillin because you're not going to appropriately treat them. And, you can, in patients with penicillin allergy, give other antibiotics such as tetracycline or doxycycline. But the problem is that really there's no other antibiotic than penicillin that's proven to be effective for the treatment of syphilis. So sometimes we consider desensitizing the patient, particularly if they have neuroinvolvement. And again, I'm not doing all this. I'm talking to infectious disease doctors who are doing this, right? And this is where crosstalk with other outside doctors comes into play. We have a lot of crosstalk and a lot of interaction with infectious disease, primary care, rheumatology, so on and so forth. And then we sometimes consider giving steroid drops that help with just kind of decreasing the inflammation, but we consider doing that after we treat the actual infection and get that controlled. And so I talked about this, and then all patients with syphilis, the infectious disease doctor gets their spinal fluid to check to see if that's positive, and they follow that, and they performed every 6 months to see if it's normalized, if there's positivity in their CSF. And then by law, any patients that have been positive for syphilis must be reported to the local health authority, so that other sexual partners can be contacted and tested as well. So that was a really interesting case. And before I go to the next case, let me answer some questions here. So in what direction do you see ophthalmology with the current advancements? What is the most challenging case you have dealt with? I'll talk about that one, but so the direction of what I see ophthalmology with the current advancements. So that's a loaded question. So with cataract surgery in specific, there are a lot of lens implants. So a cataract is basically a cloudy lens that is right behind the color part of your eye. And think of the cataract as like an M&M, okay? And the chocolate part is the cataract portion, and we take that cataract out and we put a new lens implant to get clarity of vision. So ophthalmology is going into direction of getting patients are more desiring clearer vision, and not only correcting distance vision, but also correcting their up close when they're, at that age where they have to wear reading glasses. Patients want that. They expect that now. And so we're advancing in the lens technology like crazy, and we're coming out with new technology kind of every 6 months. Right now we are probably going to get another FDA approved lens in the next several months as well that helps to correct for up close. So there's an explosion of different lens implants. In terms of glaucoma surgery, there's an explosion of different glaucoma, surgeries as well that help to get glaucoma patients. So glaucoma is a disease where it causes pressure on the optic nerve. And the way we mostly treat that is with eye drops. And, I don't know if any of you have ever taken an eye drop that you have to take every single day, but to remember that it's hard. I had LASIK about 4 years ago, and I had to take eye drops for 2 weeks only. And that was hard for me to take it. And even just the cost of drops and remembering to do the drops, the side effects, it's an issue, right? It's inevitable. It's going to happen. So in glaucoma, what we're doing is we're moving to where we do dropless stuff. So lasers, surgeries that can get you off a lot of your drops, implants inside the eye that are basically drops that I insert inside the eye. I did a couple today, which it's very quick and very easy. So we're moving in that direction with glaucoma in specific. LASIK is evolving like by every minute, trying to get faster results, faster recovery. So yeah, ophthalmology is basically moving in that direction. It's always technologically advancing, surgically advancing. So it's really great. It's a fun field because I just love how much it's advancing, but you really have to stay on top of it. So one more question. What is the most challenging part to be an ophthalmologist? So the most, I think, challenging part to be an ophthalmologist is when you have patients that have a progressive eye disease that you can't improve their vision. That's the hardest part, to deliver that news to those types of patients. And they're the low vision patients, right? That's the most challenging, I think, to be able to deliver that news, be able to have that patient understand it, because it's a lot to absorb that you can't do anything to improve my vision. But what I can always offer them is low vision therapies. That's where we co-manage with optometrists who are great in this, who are trained in this, and they offer to be able to help with their vision. I think other challenging parts, specifically as a glaucoma specialist, is ensuring patients are adherent to their treatment. And I think this is not just actually glaucoma specialists. This is like every doctor, for patients to adhere to their medications. I think that's just very challenging, especially, I guess, with glaucoma, is that you have to remember to take your drops in order to keep your eye pressure down, to prevent that nerve inside your eye from progressively slowly damaging over time. So that's pretty challenging. But again, as I mentioned, we're trying to be cognizant as ophthalmologists to treat patients so that they don't have to take as many eye drops, but safely can be controlled in their eye disease. So I think that's some challenges that we have as ophthalmologists. Oh, and then one more challenge is that sometimes patients' expectations, you have to really, really talk to them about. If a patient comes in, is like, I want this lens implant. This is all I want. And here at our institute, we offer pretty much all the lens implants. I implant all the lens implants that are available in the market. But not once you fits all eyes, right? Not one shoe fits all feet. And so I talk to the patients extensively, and that patient, if comes in and say, I want this implant to give me as a good vision distance as well as up close. And I've had a lot of chair time with those patients telling them, you don't qualify for that lens. I am not going to implant that lens in your eye. And this is the reasons why. And some patients will be like, well, I'm going to get a second opinion. That's completely fine by me, because I'm doing justice to my patient to tell them this is not what you should be doing, but you can certainly get a second opinion. That is always a great thing to do, right? So that can be a challenging thing with some patients, to have them understand why I'm not going to do something to their eye. But that makes you an honest doctor, an honest physician. And if you treat all your patients like they're your family member, you will do no harm, essentially. So, and let's see. What are the, okay, so second question, what is the difference between an ophthalmologist and optometrist? I think I answered that in the beginning of the presentation. So ophthalmologists, we go to medical school, we're either MDs or DOs. We're able to do injections in the eyes, lasers, and treat all eye disease and do eye surgery as well. Whereas optometrists, they can't treat all eye diseases. They are limited on how many eye drops they can prescribe. It is dependent on state to state regarding that. And they don't perform any lasers or eye surgeries as well. So that's the difference. But optometrists are brilliant in doing specialty eye contact lenses, as well as low vision, neuro rehabilitation for vision as well. They are amazingly trained in that. And so that's why we co-manage with a lot of optometrists in the Los Angeles area to help us in things that we are not trained as ophthalmologists in. Okay, so I am going to I see more questions, but I'm going to just go further and just show you this cool case that I saw of my glaucoma patient. And no joke, she had visited her son in Central California, and I got a call from the ER physician up there saying, oh my gosh, this is your patient. She wanted me to call you. I don't know, I see what's going on with her face, but her eye is going crazy. And so I said, okay, let's go through, tell me what you're seeing. So this was my 70-year-old glaucoma patient who I've been seeing for years. And she came in with a acute onset of a painful facial rash. Okay. And so you can see this rash is on one side of her face. And as you can see in this picture, she can't open her eyelid. Her eyelid's shut on her right eye compared to her left eye, right? She said this progressed in a matter of 3 days. First, she was feeling some kind of eyelid bumps and some tingling and some eye redness. And then this happened within 3 days. I think this is a video here. Yeah. So this is her video of her eye movements. So I'm going to have you look to your left, look all the way up to your right, and look down. Good. Look straight ahead. So you can look right now when I have the eyelid open that her eyeball, or her right eye, is outwards and down. And so that's telling me that what's going on, whatever process is going on, is limiting her eye movements in certain directions, right? She's not able to turn her eye inwards, upwards, downwards. It only is in primary position outwards, right? And you can't see it in this photo, but her pupils is dilated on that right eye. So there's a few clues what's going on. Does anybody, I'll kind of open this up, but if anybody knows what's going on here, kind of think it in your head. But the rash that is basically going on here is called zoster. I don't know if any family members have ever had herpes zoster, but this is affecting one side of her face. And herpes zoster can actually affect the eye. Again, like syphilis, it can cause any inflammation in the eye, whatever it may be. You know, it can cause a conjunctivitis, it can cause a cornea problem, it can cause retina problems, and it can cause eye movement problems. This was a pretty interesting case because it's actually rare. It's a rare syndrome to see. And so again, I'm going to go over the eye movements here. Each eye muscle is innervated by a certain nerve. The superior rectus is a muscle that moves your eye up. So she couldn't move her eye up. So that nerve is out. She couldn't move her eye inwards. That nerve is out, right? So that's cranial nerve 3. She couldn't move her eye down. Again, cranial nerve 3. So we know there's a cranial nerve 3 palsy, right? She could move her eye outwards. And so she didn't have a cranial nerve 6 palsy. And so this is where neurology comes into play. You have to know kind of the pathways of these nerves and where they run to understand where potentially the problem is. And so she also had a dilated pupil. And so when you have a cranial nerve 3 palsy and a dilated pupil, you always have to be concerned of something called an aneurysm, okay? And so I'll show you here that the cranial nerve runs close to this area of where there's something called the posterior communicating artery. And so it runs along here, the cranial nerve 3, all the way back to your brainstem. And what happens is you can have a bulging or an aneurysm pushing on the nerve. And when that pushes on the nerve, it causes that cranial nerve 3 palsy where you can't move your eye in certain directions. But also when it pushes on the nerve, there's these nerve fibers called the parasympathetic nerves. The parasympathetic nerves help your pupil of your eye to stay constricted or small, right? But when the nerves are wiped out, your pupil gets larger. So it gets dilated. I don't know if anybody's ever been dilated in the office, but it's dilated. So whenever this is happening, you have to get imaging of the eye. So in her case, she specifically had something called herpes zoster, and it's cranial motor neuropathy. And I kind of, for simplistic sake, was just telling you it's pupil involving third nerve palsy. And so you want to get imaging of the eye. So as I said, if you have a complete third nerve palsy and with a pupil involvement, and also the third nerve also lifts your eyelid up. So if you're the eyelid is shut, that means the third nerve is not working. That's what's allowing to have your eyes open. And so it's always, as I said, important to rule out any compressive aneurysm at the junction of that area I told you where the internal carotid artery was and the posterior communicating artery. So you get neuroimaging for that. And then also you want to get imaging of something called the cavernous sinus. And what the cavernous sinus is that there's a lot, like just right behind where I said the aneurysm is, there is this sinus called the cavernous sinus, and a lot of the nerves run through there as well. Cranial nerve 3, 4, 6, and also cranial nerve 5. So if you get inflammation in that area, that is what's going to cause you to get that palsy too. So we got imaging of her, and the imaging had some inflammation in that area. And she was treated, and I'll show you what the treatment is. But basically what zoster is just a virus that kind of just remains dormant in the sensory nerves after you had an initial attack of like chickenpox when you were younger. And some majority of people don't know that they had chickenpox infection when they were younger. And that virus just kind of hides out in that nerve, and when it wants to, it will just manifest as this painful lesion. And so you get a painful rash with blisters in kind of a localized sensory area. So most people get it are on their face or kind of on their chest area in kind of a strip, and it's very painful. And so you get like 2 to 4 days of the rash, and there might be tingling. You can have fevers, headaches, feeling tired. Then the rash will go away within like 2 to 4 weeks. But some people will get this like ongoing nerve pain, and it's really terrible. My mom had this, and this nerve pain lasted at least a year, and it's just kind of this sharp burning pain. The risk factors for the virus to kind of manifest itself is that old age, poor immune function, and chickenpox before the age of 18 months as well. And as I said, that this nerve palsy can be caused by, there's different reasons why this nerve palsy happens, but basically it's such an inflammation around these nerves that happen to cause this palsy. So I sent her for an MRI, and that came out negative for an aneurysm. And then the way we treat it is with antivirals. So we treat it with Valtrex or Valcyclovir, 1 gram 3 times a day by her mouth for 2 weeks. And then she's on prednisone. Why prednisone? Because it helps to kind of decrease any inflammation in the eyes. And so the recovery, most people actually do really well, and they recover within a few months to about a year. Has a good prognosis overall. And then sometimes you can get double vision when you're looking straight ahead, but she actually did pretty well. This is 10 months after I had seen her, I think 10 months, yeah. And so this is a video of how she was recently.
So I'm going to have you look all the way to your right. Good. Look all the way up. Look to your left. And look down.
So you can see she recovered really well. And
close your eyes. And now open.
And you can see she's able to open her eyes. Her eye gazes, not completely 100% able to move all directions, but you can see she improved quite a bit. And so these patients have a very good prognosis. So again, I was just showing this case because number one, it was really cool, very rare. But number two, also, again, you can see how I was working with her primary care doctor as well to manage these kind of cases as well. So it's not just we're limited just to ophthalmology. We crosstalk with a lot of different specialists who are infectious disease, primary care, so on and so forth. So it's a really great field if you want to get a mixture of different medical diseases and not just kind of hone on to one area. Let me answer a couple here. So why did I choose ophthalmology, and did I consider other specialties? So why did I choose ophthalmology? And did I, that's kind of a two-part question for myself. I'll kind of give you what my path was to becoming an ophthalmologist. So when I was in high school, my grandfather had a accident where he was crossing the road in India and he got hit by a motorcycle. And it basically wiped out his vision. He had something called a traumatic optic neuropathy. And so he came from India. My mom brought him over, and we were taking him to kind of neuro-ophthalmology appointments there just to get monitored. And so that was kind of my first dose of exposure to ophthalmology, even before I knew I wanted to go into medicine. And so I got into med school, and when I entered med school, I had no clue what I was going to do. I knew, though, I wanted to do something with my hands, like procedures, surgeries. So I knew I wanted to do that. And so I actually loved like anything with the heart, like cardiovascular. And so what else kind of had surgery and heart was cardiothoracic surgery. So I did a lot of research in cardiothoracic surgery in my medical school early on. And my mentor was the director of the CT surgery at that time. At GW. And so he was the one who actually kind of sat me down and said, would you ever consider other fields? And I think because he knew kind of my personal connection to ophthalmology, he said, maybe you should consider ophthalmology because you have a personal connection to that. Have you ever thought that? You have such great like hands with maybe microsurgery. I mean, he saw something that I didn't. And so I ended up doing a rotation kind of late in ophthalmology and did some research in it. And I fell in love after I did my rotation, essentially. Why I chose it is because it's fast-paced clinics, as I said. But you also are able to form connections with patients over time. It's instant gratification, especially with surgery. As I said, you do cataract surgery and the next day you get a gift because you get like, a really happy patient. And so that is really, gratifying that you can help people's vision for majority of the part and able to keep their function of life, because people really take for granted their vision until it's lost for whatever reason. And then basically I also loved it because, as you can see, it's a mixture of different medicine. Like I've diagnosed patients who've had diseases like lupus, sarcoidosis, herpes, as you can see, diabetes. We see that all the time. If a patient comes in and they have a kind of routine eye exam and we see something inside their eye and we're like, that looks like diabetic to me. Have you seen your primary care doctor? No, I haven't seen them in years. They go and get their testing done and they've been diagnosed with diabetes. We are sometimes the first person or people to see it, some of these medical diseases, because really no other field can like visualize in the clinic the pathology right away. There's not as many specialties. And so ophthalmology, you can see that. How do you recommend us to improve our manual dexterity if we're interested in surgery? Okay. So my attending, so Tufts Medical Center is in Chinatown. And if you really want to improve your dexterity, there's a lot of, go to like any restaurant that has like offers you chopsticks or get chopsticks. And my attendings used to take us out to like the local Chinese restaurants or Vietnamese restaurants and made us use our non-dominant hand. So I'm right hand and they made me use my left hand with chopsticks to eat my food. So over time, I forced myself to do that. And so that helped me get used to using my other hand. And it's really served me, beneficial when I've had to kind of switch between hands. I mean, that's just different ways, or you can just eat with your non-dominant hand, brush your teeth with your non-dominant hand, right? Like do things with your non-dominant hand more, and then you'll be able to kind of get muscle memory in that hand. Chopsticks are the hardest, I'll tell you. Do you have any tips for dealing with eye strain, especially during the pandemic when you're spending a lot of time in front of your screen? Yeah, I feel like I talk to every single patient about this. So eye strain, when you're looking at happens from when you're on the computer quite a bit. The biggest reason why it happens is that we are staring at our screen, right? Our blink rate, the amount of blinks we're supposed to do per minute, is supposed to be about 16 blinks per minute. When we're doing computer work or even reading, our blink rate decreases to about 4 blinks per minute, right? And so you can imagine our eyes will tend to dry out more. And when our eyes dry out more, then we get more strain in our eyes, tired eyes, burning sensation, so on and so forth. So there's a very simple rule that you want to follow, is the 20-20-20 rule. Every 20 minutes, you take a break for 20 seconds and you look 20 feet away. That will help to keep your eyes at rest. And you can also do a lubrication eye drop as well to help with that, okay? The other thing you could do that you want to make sure is that you don't have such a high contrast between your screen and the lighting in the room. So for example, you don't want a really bright screen and then a dark room, right? That will cause a lot of strain on your eyes. So kind of match your settings with your screen as well. The other thing that you could do is, we always want to make sure that you're positioned kind of ergonomically correct at your computer. So you don't want to be kind of scrunching down and all that stuff, because that can cause a lot of headaches and then strain as well. Like, people don't realize that your posture plays a huge role as well. So, and then the other thing, and this is more like older patients, but this past 2 weeks, I sent 2 patients for eyelid surgery. And why is that? And you're like, that's weird. But the reason why is that over time, gravity sets in, your eyelids drop, your forehead drops down. And so what you want to do to compensate is you lift your eyelids up like this. And so when you're on the computer, you're like this all day. And then when you're off the computer, you go like this. And then it just causes a lot of tension headaches here and kind of eye strain. So I see a lot of people come in like, I have eye strain, I have eye strain. Well, you have to do these things too, but your eyelids drop. You're using so much of your muscle here that no wonder you're getting a lot of headaches. And so, those patients got surgery and they're like, oh my gosh, my headaches went away, right? And so that's another reason too. But the biggest reason was that number one, I said, is taking breaks on the computer. We need to really be cognizant of doing that. Let's see what else. What was the main factor that led you to go down this career path instead of others? I kind of answered that before. Also, what are the other favorite parts of your profession? So my favorite parts is doing surgery. And again, that being in the OR and making a difference in patients' lives. It's also, my favorite part is that I can do procedures in the clinic as well. And I guess my favorite part is that if a patient comes in and tells me something like their symptoms, and then I can take the microscope and look at their eye and tell them instantaneously what is wrong. Sometimes, like, you can't do that in other medical fields. You have to come up with a differential, get lab testing, have that kind of waiting period, and then get a diagnosis. You might already have in your head, like, I kind of know what the diagnosis is, but you have to confirm it with testing. And for the most part in ophthalmology, you right away already kind of can tell them what their diagnosis is. So it's kind of an instant gratification that the patient leaves satisfied, like, oh, I know what's going on. And then, how complicated are surgeries involving the retina? So I'm not a retina specialist, but they certainly can be complicated. Any eye surgery can be complex. Even if it's straightforward, it can be complex. So a good surgeon is always a surgeon who has a plan A, plan B, plan C, plan D. Not just plan A, because even a straightforward surgery can turn into a disaster sometimes. So you always have to be on your toes. Retina surgeries can definitely be complicated. It becomes complicated when, especially, there's so many different ones, but for example, if you're a diabetes patient, not controlled, and you get detachments called retinal detachments, but they're not just a run-of-the-mill detachment. They have a lot of inflammation and scarring, and those are hard to fix. So there's some that are definitely complicated. Let's see, are there any eye operations or surgeries where a patient is not under sedation? Yeah, so I have done cataract surgeries that they have not gotten sedation. For certain reasons, they're not able to get sedation. Those patients are rare to come for me. Most patients are undergoing sedation when I do cataract surgeries, but some have done it without and just topical anesthesia, and they do completely fine. LASIK, we don't give them sedation. They just get like a Xanax, but not a full-on IV sedation. So yeah, not all eye surgeries are done under sedation. So, and then why and when did you decide that you want to have a career in ophthalmology? I kind of answered that. That was I was a little atypical, but I decided late, and late meaning like around early my 3rd year. And what is your favorite and least favorite part of being an ophthalmologist? So again, my favorite part I kind of mentioned already, and my least favorite part again was delivering bad news to patients that I can't help or improve their vision. Is kind of a little sad when I deliver it to the patients, and kind of understanding, having the patients understand that. That's kind of my least favorite part of delivering that kind of news. I also, I do a lot of surgeries and everything. So my least favorite part is doing what we call refractions or checking for eyeglasses. That can be very tedious. So that's kind of one of my least favorite part about being an ophthalmologist. How many types of eyesight correction surgeries are there? So quite a bit. There is LASIK, there's PRK. So LASIK is basically the surface of the eye called the cornea, the most anterior part. What we do is create a flap to lift it up, and I'll kind of show you a video, a little bit of that. And then I treat the prescription and then put that flap down. But in order for you to do that, the cornea has to have a good amount of thickness to it, okay? Because when you do LASIK, it kind of thins out the cornea. So if you don't have enough healthy tissue left behind, it can cause issues. So there are other options like PRK, where I basically don't create that flap. I just take a little tissue off the surface of the eye and then treat it, and then allow your tissue to heal over the cornea tissue. And so that leaves a safe amount of cornea behind. It's not as fast results as LASIK. So that's why, if people ask me, would you have LASIK or PRK? If you are essentially a PRK, if you have, if you're a LASIK candidate, then, and you have the option of LASIK or PRK, I would choose LASIK anytime, any day. Except if there's cases where you do like boxing or something that can increase your risk of that flap I talked to you about dislocating, essentially. So LASIK just gives you quicker results. Other eye correction surgeries are, if you don't qualify for LASIK or PRK, then there are implantable contact lenses we place in the eye. So that's an option as well. And then in older patients who have lost their ability to read up close, they need reading glasses, we actually do something called a refractive lens exchange. So that refractive lens exchange is actually it's cataract surgery, but they don't have a cataract, but it offers to not only help their distance vision, but also their up close. So those are kind of the what eye correction surgeries that are out there. And then I kind of already talked what motivated me to go down this path. Do I use general or local anesthetic? So for my majority eye surgeries, I use IV sedation. I will do general anesthesia if for some reason that they're at high risk of that they can't relax their eyes or they squeeze too much. Even that I use IV sedation. But if they have terrible posture, I need them to be under general and kind of relax. So that was not an issue with posture, that they're uncomfortable. So there's different reasons why I use general anesthesia, but for the most part, there's more risk to doing general anesthesia than benefit in eye surgery. I use local anesthesia if I'm doing like eyelid excisions, eye bump removal. So that's kind of how I do local anesthetic. So I just do a lidocaine injection. And then most of the other kind of procedures on the eye, we use topical eye drops. So just proparacaine, and it just kind of numbs the eye for about 15 to 20 minutes. And then what majors and classes do you recommend in college? So I'll touch base on this a little bit later, but basically all the majors that, as long as you can fulfill the pre-medical requirements, you can major in anything. I majored in biology, but I also minored in dance and dance and religion. And my parents freaked out when I minored in dance because I thought I would go into like the arts, fine arts. But yeah, I mean, med schools are looking for kind of a variety of majors. They just want to see a well-rounded candidate. That doesn't mean that if you love biology, do biology. Doesn't mean that you have to do like art history or whatever, something that you don't like, just to show that you're a versatile candidate. Do something, just as long as you do what you love, then it will come out in your interviews that you love to do this. You love like biology, you love dancing, whatever it may be. And they see the honesty in that. As long as you're honest and you're transparent in your process, they love that. And they interview a ton of candidates, so they know when somebody is, BSing and not. So just being honest in your process. And then, are we doing okay in time? Okay.
So I'm going to have you.
Oh, let's go forward. Okay, so let me show you in ophthalmology what I'm talking about, instant gratification, like when a patient comes in and you can diagnose them right away. So these are kind of spot diagnosis. So for example, that is glaucoma. This is the optic nerve. It's the nerve that goes from your eye all the way back to your brain. Think of it looking like a donut. The picture all the way to your left-hand side is a normal nerve, and you can see the whole of the nerve getting larger and larger and larger, so that you can see as glaucoma. This happens over years, but you can easily diagnose this. This is a chalazion. I don't know, maybe one of you guys have had this. This is basically a blocked oil gland. This is kind of a quick spot diagnosis, and you can treat this with warm compresses. You can do excisions of it, other kind of what we call IPL. There's other kind of treatments we can do for this as well, or steroid injections in this as well. This is herpes simplex, not herpes zoster. And so these are called dendrites on the cornea. It's actually very beautiful to see, but the patient, it's in pain. But we treat this again with the antivirals. This is diabetes. So if a patient comes in for their eye exam and they have this in the back of their eye, they most likely have diabetes, and this will present in both eyes. And this exudate, we call it, is indicative of some macular edema or swelling in the macula. This is a retinal detachment. Okay, you can diagnose this right away. Patient is saying, I'm coming in with a curtain coming over my vision. I've seen flashes or floaters. This you have to treat with either a procedure. You can do a procedure in the office with a gas bubble or surgery. And then this one is a corneal ulcer. Oh my gosh, where'd it go? A corneal ulcer. So that they come in. Most of the time the story is, I slept in my contact lenses, now my eye is hurting. And well, actually, let me tell you how the story goes. They come in, my eye is hurting. This is what you see. You ask them, are you a contact lens wearer? Yes, I am. Have you slept in your contacts? No, I don't sleep in my contacts. Are you sure? Maybe once the night before. And then they present with this. So this you have to aggressively treat with antibiotics on the eye. So again, it's a highly surgical based field. Here I'm performing cataract surgery. And again, here is cataract surgery sped up. So we do an incision in the eye. Here, okay, let me pause this for a minute. So right there, think of that M&M analogy. The shell, you want to make a little hole in the anterior part of the shell to access the chocolate part, right? And so think of a peanut M&M. I'm going to take out the peanut part. So that is right here. We use this ultrasound probe to break up the peanut part inside the eye. And so here I'm breaking it up. And I'm going to remove the peanut part out. Here I'm just removing it. Coming out slowly there. And then after that's all removed, I'm going to take another probe. This is called the IA probe. Basically, it will take the outer chocolate part out, the shell that's left behind. And then there's a thin shell left behind. And that thin shell, I'm able to put a lens implant into the eye. And voila, that's it. And so this patients right away notice a vision improvement. The surgery takes about 10-15 minutes to do. Pretty much no sutures needed on the eye majority of the time. Sometimes I do put a little suture that dissolves, but it's a really quick recovery, and they're seen right away as well. Oh gosh, I'm terrible with presentations. Here, this is a video that I'm performing LASIK. And at the end, you'll see kind of what the LASIK patients, they get excited when they can read the 2015 line the day after. So let me put this. So here's the machine I'm creating, that flap I was telling you about. So I'm going to create the flap. There's the flap I'm lifting up. I'm treating there, the eye with their prescription. They're usually really happy that they're done. This is the day after.
Okay. PGNKO. PRNKBU. NTDABZ.
This is smaller than 2020.
Ooh, okay. OHPNTZ.
Got it.
Did I really?
Yeah.
So you can see patients are extremely excited after their vision improvement, especially with LASIK. It's a really quick recovery. Patients are able to drive the next day after their surgery. So very, very gratifying field, as long as you do it in the right patients, right? So advice for pre-meds. So what mine was atypical because I was already accepted early into med school, so I can't give you advice about the application process and taking the MCAPs, but I can certainly give you advice how to prepare and strengthen your application, because I kind of went through that when I applied early and I still had to do the interview process for med school. So you want to meet, like most colleges have a pre-med advisor. So you want to meet with them, get their advice on choosing classes. If you're interested in a major but want to fulfill pre-med requirements, they can tailor your schedule or help you tailor your schedule or give you advice for that. You also want to start extracurricular activities early on. Like, don't wait until third year of college to do extracurricular activities. You want to do something early on because you want to build on it over time. And they'll also see that, oh, on my third year, you just like started to do a lot of extracurricular activities. So you want to just do some interesting, things that you enjoy. For example, for myself, I love dance. I was trained in dance. I actually started a dance club in college, and I taught underserved kids in the DC area, Indian dance. And so that was something I built on over time. And I did infectious disease club as well, that we outreached on different infectious disease like clinics and everything. So that was kind of things that I did. You want to hold a strong GPA throughout college. One thing I've seen is that in freshman year, you kind of are like, oh, I can go a little relaxed. And then later on, like, oh crap, I need to like boost my GPA because I need to apply to med school. You always want to hold a kind of strong GPA throughout college. And then work on your CV or your resume starting freshman year. Like, just put a resume down, because then you'll be able to apply to research positions, give it to your mentors to review. And so that last minute, you don't have a resume at the end to kind of scramble. And so that you also don't forget to put stuff on your resume as well. And then the other thing, which I think was really important, is think of your recommendation letter writers ahead of time, so that you can build relationships with them. For example, I got one from my physics teacher, and I loved physics, and I kept a good relationship with him. He knew me. And so he could write me a strong letter of recommendation. That's the key. What you want is a strong letter of recommendation, not just your letter of recommendation. So think of them early so that they know you and so they can write that strong letter of recommendation. And again, major and minor in whatever you're interested in, as long as it meets your pre-med requirements. And then get advice from medical students, from other doctors about the application process. Shadow them as well. I have pre-med students shadowing me all the time. With COVID, it's slowed down, but if you're interested, find me on Instagram, message me. If you're in the Los Angeles area, I can arrange a time that you can shadow me. And you can also watch me do surgery. You just have to arrange it ahead of time. And then again, I already went through why I chose ophthalmology, but these are the reasons: the personal connection, the fast-paced clinics, diagnosis are very highly visually dependent. You could be the first provider diagnosing all the medical diseases. It's a different blend of different medical diseases, highly surgical field, instant gratification, and you form long-term patient relationships as well. So that's my Instagram handle. I also have a TikTok, which is the same, but you can message me if you're interested to shadow me. Be happy to arrange something. Even if you want to see me operate as well, you just need an updated TB, PPD, as well as a flu vaccine. So, and then we can always arrange that as well. Did I answer all of these? Let's see. Is the common saying that carrots improve eye health? So carrots have certain vitamins that help with eye health, but it's just not limited to carrots. You want to always eat a healthy diet, rich in antioxidants like lutein and zeaxanthin that helps with preventing a lot of eye diseases. So it's just not limited to carrots. Is brain function affected by vision loss? Yeah, so there are a lot of neurological conditions that can cause vision problems. So for example, I had a patient 2 weeks ago who had some vision issues, was sent to me for a glaucoma consult. I looked into the eyes, just was not adding up to glaucoma. I got certain testing in the clinic, and right away I knew that there was something neurologically happening. It was just not limited to the eyes. I sent them for an MRI, and they ended up they actually had a stroke. And so that was causing their vision problems. So they're connected with a neurologist getting treatment for that. What is the recommended age to get LASIK? So recommended age, minimum 18 years up to around 40 years of age. But definitely you can get an evaluation to see if you're a LASIK candidate. Is it possible for humans to naturally enhance eye vision without glasses, lens, eye surgeries like LASIK? So no, your vision prescription is dependent on kind of genetically already. Some people have longer eyes. When you have a longer eye, you are nearsighted. Your eye is just weaker. And so you need glasses or contact lenses or LASIK to correct that. And then if you are farsighted, your eye is shorter. So there's nothing to naturally enhance your vision. What is the most rewarding part of being in ophthalmology? So I love surgery. So instant gratification with the surgical aspect of that, where I can improve patients' vision and right away they are grateful for that. For ophthalmology, what other medical branches do you need to know about, like neurology for a herpes patient? So for ophthalmology, you need to know your neurology. So especially your cranial nerves. You need to be familiar with the pathway of the optic nerve, how it kind of goes back to the occipital lobe. You need to be aware of how they kind of innervate the brainstem. So that all helps you because it helps you to localize where the problem is. So that patient that I showed you, I showed you kind of a step-by-step of how you figure out where the lesion is or where the problem is in that eye. What is the worst case you've encountered as an ophthalmologist? So the worst cases that I deal with is, and I feel kind of bad, is that a patient comes to me and they have not had an eye exam for 10 plus years or whatever. And they come to me and they have a progressive disease that could have been caught early, but now they came to me so late, I cannot improve their vision. That's the worst case, that I can't improve anything, but there could have been an intervention ahead of time. There could have been, if they came to the eye doctor ahead of time, it could have been delayed. It could have been prevented. Those are the worst because I knew something could have been done beforehand, right? That's why it's so important. That's what I do on my Instagram is eye education. And it's so important to kind of, if whatever field anybody goes into or whatever you guys go into, educate the masses about prevention, how to prevent any medical problems from happening so that they understand. Have you conducted any research on eye diseases and vision disorders? Yeah, so right now we do a lot of FDA trials in private practice. So you don't necessarily need to be in an academic center to do research trials or FDA trials. In our private practice, we have a lot of FDA trials that we do. We work with a lot of different companies. So currently I am doing FDA trials on specifically a glaucoma surgery. What is the longest eye surgery you've had? Oh God. So typically my eye surgeries are about 15 minutes. I've had other longer eye surgeries can be glaucoma surgeries, which can be about 30 to 45 minutes. My hardest surgeries I've had were about 2.5, 3 hours. That's the longest I've ever had. And it was exhausting for me because I'm not used to operating that long. We do sit down while we operate. We sit at the microscope and we use our hands as well as foot pedals as well. And what causes lead to the need for LASIK eye surgery? So LASIK eye surgery is an elective procedure, meaning that you don't need it. You don't necessarily need it, but it just helps you to get out of glasses. So if you are nearsighted, farsighted, those are, and wearing glasses, you can, and you hate wearing glasses, you can do LASIK. Other patients that if they don't like wearing glasses but they wear contact lenses, but they're terrible with their contact lenses. They sleep in them. They have bad contact lens hygiene. I recommend LASIK for them because they're going to do more harm than good with their contact lenses. I see more infections from contact lenses than I've ever seen with LASIK. Knock on wood, I've not seen a LASIK infection under my hand, but with contact lenses, they're a medical device. You putting in the eye. If you don't have good hygiene, washing your hands, when you take them out, when you put them in, you're going to get an infection. So those types of patients, I do LASIK on as well. I offer them LASIK. I think that's it. There are no more questions.
All right. Yeah. Thank you so much for your talk today. It was definitely very eye-opening. Pun intended.
No pun intended.
But yeah, it was actually really informational. I definitely learned a lot for sure. And I really loved your analogies. That definitely helped me visualize it a little bit better. But yeah, so thank you so much.
Of course.
And for everyone else who is still watching, make sure to fill out the Google Forms to get your shadowing hour. But yeah, thank you so much.
Thank you so much.
All right.